Hello and welcome back to the show. Today we are going to be diving into a women's health topic. I haven't done one of these for what feels like ages, but I'm pretty sure it's been maybe 2 months because I like to rotate topics. So I do two a month. It's usually either a business related topic or a women's health related topic, or now a special guest. So I've had quite a few interviews recorded. I think there's only 2 episodes that have gone live with guests, and they're EPs in their own cool space, and they'll either be some sort of mindset and business related topics or practitioner based skill set or women's health as well. So I have a couple more coming that I've already had the pleasure of recording. And I'm excited to share them with you because one, I feel like all of these people are really awesome that I'm meeting. Two, I'm actually doing better at networking, which if you've listened to my earlier podcast episodes, you know that I've never really been a networker. I've never really been in the scene of things. I kind of just like, I'm a little bit of like a lone wolf. Like I just do my thing and that's it. So I'm really challenging myself at the moment to reach out, network, connect. So I feel a little bit proud of that. And if you're not doing that, I would highly encourage you to do that because kind of wish I did it a little bit earlier in my career, but we're here anyway. So, yeah, they're really awesome. And the other thing is, like, I really feel like there's so much value within our industry and we just never really hear about it. So, I'm hoping to share that with you. So, if you know anyone or if you are someone and you have great, well, you just think you want to share something, reach out because I would love to have more guests on the show and start sharing more insights into delivery modes of service, business, women's health related content, maybe a cool EP journey. I've met some really cool EPs lately who are doing things really different and aren't just in that regular clinical exercise physiology role that seems like what you do with this career. So I want to share that there are multiple ways that you can grow your career and go in different directions. And it's not just as standard exercise prescription or group classes. So stay tuned. Yeah, I'm excited about that. So those are the three topics that I usually tend to cover in the podcast. Hopefully you resonate with all of those, or at least one of the topics, and that's what you tune in for. But thank you for being here and thank you for sharing them. I've noticed a lot of new people are coming into the show and listening to what I have to say. So thanks for being here. We're pretty raw, we're pretty real here. So if you don't like that, I suggest you exit now. Anyway, I want to give you a little bit of an update with where we're at in life outside of the actual podcast. So if you follow along my stories, you would have noticed that I'm doing a little bit of work in person at like a wellness clinic. So all of my work is virtual aside from this random one afternoon a week that I'm literally doing to get out of my house and make friends in the area. Because if you have been listening to me for a while, you'll know that I did a little bit of moving around, stayed in my house, worked from home, and didn't really make friends. That was because my partner and I move around a lot for his work. And I kind of felt like it was pointless because I'm like going to be here for 2 years and then I'm moving on again. So I didn't do that. But I was like, you know what? I really need to make an effort. So I did. Also committed to networking. That was another reason why. So I've gone into some in-person work, which is blown my mind at how different it is compared to virtual care. And it's also reminded me of like, it was almost like you know how like you start to learn a skill and then you don't realize how far you've come in that skill until you go back and do something that you used to do. If you have no idea what I'm talking about, then don't worry. But that's exactly how this feels. I haven't delivered care in person in terms of women's health stuff for so long. Well, not that long, 3 years, 4 years. This is the fourth year. So a while. But just going back into in-person consults was like, wow, I definitely wasn't like this when I was doing it 4 years ago. So it was quite nice to see like, oh yeah, you actually are getting a little bit better at like your clinical skills. So I would encourage you to take a little bit of a step back and look at how far you've come, reevaluate, and know that you are actually progressing. Sorry, progressing. Don't know what that was. Anyway, so I'm doing that little bit of in-person work, but we have been trying to promote that clinic. So I'm not really there trying to grow that in-person stuff because it's literally for me to be social and meet clinicians and have a great time outside of my house. But obviously the lady who runs the business is. So she is looking at networking, looking at events, and we did a pregnancy, babies, and beyond expo. Now, if you follow my stuff, you'll know that I do pelvic health a lot, and a lot of my work is actually not within pregnancy and postnatal care. I used to do a lot of that, but then I just fell more down the pathway of pelvic health conditions that are outside of those, I guess, that time period in the female life cycle, which I love because I really honestly believe it needs to be addressed outside of just pregnancy. And I love being able to support women who are outside that space and feel like a little bit unheard in a sense of their symptoms and problems. So for me, I was like, oh, pregnancy, babies, not my thing. I don't have kids. Not really sure if kids is even something that I do want. So I was excited to like do an event, but I also was a bit like, oh, I don't really know how I'm going to go at this event. Anyway, she was like, oh, bring all your flyers, bring all your business cards. We're going to promote. And I was like, oh my gosh, I don't have this stuff. I don't give out things because I'm online. And if I'm linking in with people, it's usually like a digital PDF or here's a link or here's my website. So I was a bit hopeless, if I'm honest, about running anything at an event. And I just basically printed up some like PDFs with like QR codes to scan and chatted to everybody. And it was really, really interesting because I live in a regional town and I haven't really been in the community in a sense of clinical work. So I haven't really seen a lot of, I want to say, trends in healthcare or what types of clinicians people go to see for their health problems or pelvic health problems, especially. And they were all like, exercise psychology or physiology, like didn't really know what the hell I did. And explaining it actually became interesting because I just feel like it's not an easy thing to explain when someone has absolutely zero idea about exercise or movement or anything related to their health, and trying to teach people that at an expo where there's all other people there was actually really quite challenging. But it was really interesting to hear that a lot of people had already sought out other avenues of care, whether that was osteo, myo, whether it was physio, but a lot of them hadn't actually done any exercise, and they were really interested to know about this and how it actually made sense to them to like train the muscular system. So it was really nice to be able to reach out and connect with people and see what was missing in a regional area. And I do actually do a lot of care in regional areas, although it's all virtual. So people are already finding me and they already know that they are looking for something like me. So it was interesting to see that, yes, this is actually something that is missing in regional towns in person, or at least in my area, and is a route of, I don't know, business growth, I guess you would call it, if you were in person. Anyway, so I'm interested to see what comes about from that. But I did also meet a lot of clinicians at this event who were like pregnant or postnatal, or they were just also interested to see what was at this expo. And it was so nice. I met some really nice clinicians, some EPs, some chiros. I met some other physios, and they were all so positive, which was also really great. So I've teed up a few coffee dates and hopefully we'll get some new friends, which we all know has been a challenge for me, being that I don't know how you meet people when you're old and you don't have kids and you don't go to a workplace and you don't play a group sport. Like, where else do you actually meet people? So, yes, I'm excited about that. And I felt like it was, a positive start because they were also running their own business, and they were also in healthcare. So there was quite a few things in common, which is nice. So, yeah, I'm looking forward to that. And who knows what that will look like in the future. But that's what I've been up to in the one-on-one clinical in-person space, shall we call it. virtually the business. The mentorship is in the 6th month now. So we're in the final month of content. We're going through hormones and its impacts on pelvic health. So we're looking at the menstrual cycle. We're looking at transitioning into menopause. And we also cover endometriosis in that module. So it's basically like, we know that all these pelvic floor issues are a problem. We know that there are different ways of treatment. Now, what do we need to consider in regard to all of these other things to then layer onto the programming? So I actually quite like this month because it's like to the point, all about hormones, but it's also mostly about the pelvic floor concern in regard to that. So that's the final month of content. We are moving into then to bonus support. So we're going into monthly group calls. We are going into more exercise prescription or workshopping. And we also will cover some additional case studies, and hopefully everybody else does their homework and brings some questions and some case studies of their own. So that might be their own clients. So if you are interested in learning more about pelvic health and really diving into it inside the mentorship program, I actually have had quite a few of you reach out in the last couple of months wanting to join this, and it is not actually open as a regular intake. It is a once a year thing. So in December, it will open up again for 2025. And at this point in time, I am planning what that might look like. So I have done a little bit of change to the program every single year because I'm all about, improving it. And so if you are interested, I will be starting a wait list for this. You can either reach out to me now and send me a direct message in Instagram, or you can send me an email and let me know that you're interested, and I'll start the wait list more officially in a couple of months when it gets a little bit closer. But I have had a lot of interest in that and other forms of education. So there will be some new things coming next year for those who are interested, also in stuff that might look like something different to a mentorship. So if you're not really like a 12-month program, well, it's actually 6 months. 6-month program, and you still want to learn about it, but maybe not as deep, there'll be some other formats of that. So stay tuned because that is exciting. Outside of that, that's pretty much the update from this end. Before we dive into the content of today's episode, I just want to ask a favor, share, tell your friends about this podcast if you think it's valuable. I really want to be able to grow it a little bit more and bring on some really cool EPs. And to do that, it needs to reach new people. So I would love for you to share this on your social media, with your colleagues, with your boss, whoever it is that you think would find value out of this, so that I can reach more people. So that would be extremely helpful for me. So yeah, please do that. Anyway, let's jump into today's episode. We are talking about C-section deliveries and the impact they have on the muscular system and the fascial system. So if you're on my email list, you'll know that you get monthly research spotlights where I send out an email the first of the month, and it basically goes through a piece of research or an article that I quite enjoy, give you some take-home messages, and Bob's your uncle. So this one, because May was the postnatal module in the mentorship, I was updating all of that and I was going through research, and this was one of the papers that I really quite liked. So I wanted to share it. So I did this for the 1st of June. So if you were on that email list, you would have already received this, but this is the, let's say, verbal version of the email. So let's dive into it. The research paper is titled Effects of Cesarean Section and Vaginal Delivery on Abdominal Muscles and Fascia. So this is an interesting paper because the results I felt were like all over the place. And I was like, what the hell am I supposed to take from this research paper? But when I really thought about it and what I do in clinic, it really helped shape some things. So I want to talk a little bit about it. Now, the purpose of this study was actually to determine whether or not abdominal muscles and fascia differ in women depending on whether they've had a cesarean delivery or whether they've had a vaginal delivery. So the people who obviously put this together really wanted to understand more about how fascia responds to different delivery modes and how maybe the alterations within the systems relate to things like scar pain or abdominal pain, low back issues or low back pain, and even things like pelvic pain. So there was a couple of things they were looking at. Now, in regard to the study, what they actually did was recruited women that fell into 3 groups. So we've got like non-birth or nulliparous, don't know how to say that. Nulliparous. I don't know. It sounds weird. Whatever. No children, no birth is what we're talking about. Then we have the two other groups. We've got women who delivered via cesarean delivery and then women who delivered via vaginal delivery. So they had kind of like three groups. The women who were in cesarean or vaginal delivery had to have given birth at least 2 years ago. So they had to be, 2 years post-delivery, shall we say. Only one child, and they had not taken part in any rehabilitation program, not have had any abdominal surgery, or they haven't had any trauma-based experience from during the postpartum delivery. So they really did eliminate any effect outside of delivery. They were trying to really reduce that and knuckle down to, was it cesarean delivery or vaginal delivery impacting this? Now, all of the participants in the program or in the study underwent ultrasound imaging to evaluate the abdominal muscles and related fascia in supine positions. And they measured a couple of different spots. So they looked at the linea alba, and that was like above the navel. And they wanted to measure the thickness of the linea alba and the interecti distance. So I guess we're also looking whether there's any sort of diastasis there, but it was mostly for fascial function. They looked at the rectus abdominis, and this was like at the level of the belly button and the thickness of the rectus abdominis. They looked at a lot of different layers in that, and it goes into more inside the paper. But for the sake of this and keeping it simple, we'll just say rectus abdominis. And they also looked at the axillary line. So that was sort of like more lateral areas of the abdominal wall in line with the navel. There was quite a few layers of fascia and names of groups of fascia that I was like, I don't even think I have heard of that before or understood all of that. So I actually did have to Google a few of those things and have a look at it, but it was actually really nice to see like, oh, there are all of these really different layers that I guess that are classified into different names. So if you read papers like that and you come across words where you're like, what is this? I've never heard of this. Like it's same. I do that all the time. And sometimes I feel like it's nice to hear that other people also feel like that when they read papers, because sometimes I just feel like an idiot when I'm reading them. And I'm like, I've never heard of these before and I don't even know what that means. Or the way it's written is like just confusing. So I really didn't gel with research when I was at uni for this reason. So have a very different take on how I read research and then how I actually use it. So hopefully that resonates with you too. But yeah, so anyway, that's where they're measured. Cesarean section deliveries and vaginal deliveries completed, the women in those groups also completed a questionnaire about pain, and they were asked to rate pain according to a visual analog on a scale of 1 to 10. And they were asked about pain that was on their scar in areas of the abdominal wall, the lower back, and the pelvic floor. So there was quite a few things that they looked at in regard to pain. And then they were also answered in that questionnaire how long the pain had lasted after their cesarean section delivery and the vaginal delivery, obviously for both groups. And the options for that were less than a month, 1 to 3 months, and then more than 6 months. So we're looking at really short term, moderate, obviously, and then a bit more long term. Now, what did they find in this study? This is where, when I was actually writing this down for the email, I was thinking like, this is confusing. There's like a million different variations of results and which fascia is related to which fascia is affected and what side of it and blah, blah, blah. So I'm going to read a little bit of it from my notes here. And they kind of broke it down into muscle measures and then fascial measures. So they broke it down in terms of the results. Now, in regard to the muscle measures, rectus abdominis was significantly thinner on the left-hand side in cesarean section women and on both sides in vaginal delivery women compared to the non-childbearing group. Rectus abdominis in the vaginal women was significantly different between the right and left sides of the body. The left total abdominal muscles, which was external obliques, internal obliques, and transverse abdominis, was thinner in the vaginal delivery women compared to the non-childbearing women. It says mainly due to the left internal oblique. So when we look at like all of those together, it was that particular internal oblique, which was obviously lacking a lot more than the rest of the muscle groups. The right internal oblique in cesarean section delivery women were significantly thicker compared to vaginal delivery women. and the internal oblique in cesarean section women presented with significant differences between the left and the right sides. So like a little bit all over the place, if I'm honest. I was like, yeah, okay, cool. Now what else? Now, in regard to fascial measures, cesarean section women had a wider interrecti distance compared to non-childbearing women. There was no difference between the three groups in regard to the thickness of the linea alba. I thought that was a bit odd. Looking at rectus sheath, cesarean section women had significantly thicker right rectus sheath compared to the nulliparous women, and loose connective tissue between sublayer of the posterior rectus sheath on the right and left sides in cesarean section women were significantly thicker than the vaginal delivery women. That was like one of the measures that was in between that whole rectus abdominis measures. So they had different layers and they were measuring different things. So I found that a little bit confusing to visually even look like I'm a visual person. So I would have loved to just see a picture of it. But anyway. Left and right sides of the abdominal perimuscular fascia was significantly thicker in cesarean section women compared to the nulliparous women and the vaginal delivery women. So yeah, still another paper that I'm like, feels like it's all over the place. Nothing really tells me anything. Pain outcomes were interesting. I don't really want to read this whole section out to you because I find that you'll just get confused with all their figures. But let's just go with like, if you want to know more about these, I would, all the link for the paper will be in the show notes. So you can dive into the results a little bit more, or hopefully you got my research email and you can see it on that. Or I will also eventually be putting this into like a written post somewhere for you to read. Stay tuned for that. It's in the works. So for cesarean section women, 100% of women complained of scar pain. And that was actually rated mild, moderate, and severe. And 54% were moderate pain. And then it was like 15% mild and 31% severe. So really like mostly moderate pain. And majority of the women were, I think it was, there was only 13 women in the cesarean section group. So the groups were also quite small, but 5 of them reported the pain for less than 1 month. 4 of them reported it between 1 to 3 months and 4 between 6 or more months. So when we think about like how this all pans out, all of these results across the pain measures were like a little bit scattered in the groups, which is like nothing really kind of said pain is associated with this. And that is actually one of the outcomes of the study. But so 100% complained of scar pain. Don't forget this is cesarean section women. 12 out of the 13 women suffered from abdominal pain that was widespread across the abdominal wall and even at sites distant to the cesarean section incision site. So they were all over the abdominal wall rather than just on the cesarean section scar. So that was something I thought was quite interesting. Most of that was between less than 1 month or 1 to 3 months. 10 of the 13 women complained of low back pain, mostly around that moderate scale rating, and majority, so 5 of them were less than 1 month, and then 3 were in the 1 to 3 months, and then the rest were in the longer than 6 months, which was only 2 out of 13 people. And then pelvic pain was defined as feeling pain in the lower abdomen and the perineal or genital area, of which 8 of the 13 women in the cesarean section group suffered from this. 5 rated it as a mild rating and 3 for moderate, and they were mostly less than a month. I think the others was only like 1 person outside of them. So like not really, like I would, sometimes I think of this research and I'm like, I find that hard to believe. But then again, I feel like I only see people who actually have the problem. So we're like, if you're a clinician seeing these women, most of the people that are actually seeing you are the ones that have the problem. So it feels like it's a lot of people, but in reality, you're not really seeing the people who don't have the pain or the problems because they're not seeking help. It's not a problem for them. So I also like to keep that in my mind because I feel like sometimes research doesn't really replicate what I feel I see. But anyway, food for thought. For the vaginal women, the pain rating, only 1 woman complained of pelvic pain in moderate form for 1 week, and the others had no pain. So winning for them, no pain, vaginal delivery. I feel like the vaginal delivery itself would have been painful, but it wasn't, probably not a question on the research paper. But anyway, That was sort of like the breakdown in terms of the pain. So when they measured the results, they did the muscle measures, they did the fascial measures, and then they did the pain measures. So moving on from that, what were the correlations between abdominal thickness of the affected abdominal muscles and fascia and clinical measures? So this was interesting. The duration of scar pain correlated moderately with interecti distance. The duration of abdominal pain correlated moderately with right and left side rectus sheath thickness, as well as the loose connective tissues between the sublayers. The duration of low back pain correlated moderately with rectus sheath and left abdominal perimuscular fascia. And there were no significant correlations between the thickness of the affected abdominal muscles and fascia and pain. So I just feel like there's so much random results. And when I actually do say this out loud, especially now that I'm recording this for you, I feel a bit confused about what is the point of this from an exercise perspective. And I feel like this can be pretty common in a lot of papers. And if you feel like that, I would have just been like, I feel like, those times where you read paper and I'm like, I don't know, I'm not into research, like super research, like nerdy research. I just like reading it and figuring it out and like problem solving things all over the place. And I sometimes feel like I go through the paper and I'm highlighting and then I get to the end and it's like, no correlations were accounted for. And you're like, what is the point of this research paper? Why did I read this? Anyway, this is what I want you to take away from what we've discussed here. How can we apply this? I feel like there were 4 key takeaways for me. The first one is that the abdominal wall and tissues can be impacted differently between the left and the right sides of the body. A lot of them were like measures that were different between the left and right side. Now, in this paper, we can see that there is some significant dissymmetry between the same tissues on the left and the right sides of the body in quite a few of the measures. And this becomes really, really important when we're rehabbing the abdominal wall, when we're looking at healing a diastasis, when we're resolving one-sided pelvic floor tension-based issues, and even when we're dealing with one-sided low back pain or hip pain on one side. We really need to think about the symmetry of muscle strength and function on both sides of the body to get the best outcomes from the client, because we're going to have different force production based on that. And sometimes that can be irritation and pain. Sometimes it can look like poor motor control patterns, whatever it might be. So we can really see that they're affected very differently from right and left sides of the body. And sometimes our programming might actually look like right-sided only prescription, left-sided only prescription, or we're going to do this on the right side, but this on the left side. So we need to keep in mind, because I feel like sometimes we just go into this automatic habit of like, oh, just do this and it's both sides and make it even, and it doesn't really actually make it even. Just keep that in mind. Second point was the C-section deliveries impact both the muscles and the fascial systems or tissues, shall we say, whereas the vaginal deliveries really only seem to show alterations in the muscular system. So when you go through all the results, when you're reading them and you can highlight them yourself, and it makes more sense if you're someone who likes to visually see it rather than hear it from me, we can see that you can see that most of the issues in vaginal deliveries were purely muscular, and the C-section was impacting fascia as well. Now, when we're actually looking at helping clients recover from a cesarean delivery, we have to consider how the scar has impacted the function of fascia. It's really important for fascial layers to have like a really nice sliding mechanism over the top of each other, and the presence of scar tissue and adhesions or tightness in areas can really be impacted by this. When I'm in clinic and I'm teaching women core retraining and they're really struggling to connect with their deeper core muscles, whether it's the pelvic floor, whether or not we're looking sort of through transverse abdominis or those deeper layers like internal obliques, the first thing that we have to look at is any abdominal scar tissue. And that could look like cesarean section incisions. It could look like incisions from abdominal surgery, from hernias. It could look like endometriosis, excision surgery, where they've got multiple keyhole surgery, anything. It doesn't have to be C-section deliveries, but obviously today we're talking about cesarean deliveries, so that's what I'm referring to. But all of that can really become problematic. Mobilizing this and encouraging a better fascial connection and gliding mechanism and movement between tissues is really, really important in these women. And this is where manual therapy can become really helpful, because I know a lot of women don't want to touch their scars. They have a lot of issues with that. Sometimes they don't want other people to touch them either, but they might actually need a external person to go through scar tissue release with them. So keep that in mind. If they're having a lot of hard time connecting to it and you haven't looked at this yet, maybe it's thick, maybe it's chunky, maybe it's like shelved a little bit. Everything's sort of really stiff through there. There's a lot of tension and pulling. Referral pain into scar during intercourse can also be a really big indicator that there's stuff going on through there that's more fascial function. So that's the second point. The third one is that the abdominal wall muscles can be, and it is clearly from this research paper, all impacted really differently. So rectus abdominis and internal obliques showed the most changes in this paper, which means that we really need to look at specific core exercises that target these muscle groups more than others. Obviously, you need an assessment for this and you need to really look at it, but it's really nice to keep in mind that specificity in programming could actually be the key, or is key, for these women when we're restoring function and movement. So if they're super lacking in one muscle but really strong in others, or maybe they haven't really retrained everything, then it can be really helpful. Remember, we also have that left and right side issue as well. So whether the left side is working better than the right side, that could also be impacted. And then the final point is that cesarean section women experienced more pain than the vaginal delivery women. That can last between 1 month and longer, but can also longer than 6 months, really. That was sort of the only thing they measured. They didn't go past that, but longer than 6 months can be still present. Not really, like, it wasn't associated with things, and there was no real like, yes, this is going to be painful for somebody. But I think when we're looking at cesarean section recovery, it's not a stock standard timeline. When we look at clients and their recovery and how their bodies will feel and how they heal, they're all really, really different. So we can do lots to foster recovery, but it may actually take a while for someone compared to someone else who's also had a cesarean delivery. So we need to be a little bit mindful about that and remember that no two clients are going to be the same. And if you already blanket ruled everybody, then I guess probably haven't dived into that much research anyway, but it's just really nice to see that, like, sometimes the research tells us these things that aren't really like, I don't know, I sometimes feel like they're not really replicating true practice. But we can take away different things and then look at how we do things a little bit differently. And that's sort of what I really feel like is helpful to see in this paper. The results are a little bit all over the place. They don't really tell us like, yes, this is going to be a thing. No, this is not going to be a thing. We can almost assume that this is going to be an issue or whatever it might be. It's more about like, how does this show us what's happening to each individual body, and what can we then use forward in our clinical practice to really help the person standing in front of you? How do we understand the research and know that what could be problematic for this person, or what may not be problematic for this person, or what else do we need to consider? The fact that left and right sides are going to be different, that fascia and muscle effect might be different, whatever it might be. But I like to really think about it from that perspective. So I hope that's really helped you in maybe seeing research in a different light, rather than this is what proved this. You know what I mean? Hopefully you're understanding, and I'm explaining this quite well. Well, I'm explaining it well for you to understand. But I really hope that if you feel confused about some research results sometimes, that you can then look at it and take away different things like what I do. So yeah, that's the paper of the month. I will be sending another one out on the 1st of July. So if you're not on the email list, you can subscribe to that. You will get the email sent directly to your inbox. I know a lot of people are saving these and using them for their own little database, which I find really cool. So if you are doing that, let me know, because I'd like to know that these are actually helpful for you. If you have a research paper that you think is really interesting, I'd love for you to share it with me. I'd love to read it and do my own little review on it if you think that's something that you would like me to do. But otherwise, that basically concludes today's episode on cesarean section deliveries and its impact on the muscular and fascial system. And yeah, have a fabulous day wherever you are. Thanks again for listening, and I will see you in the next one.